Hello, good morning, everybody. We are group four.
I'm Cesar.
I'm Christian.
Claire Ladan,
Faith Garcia.
I'm Josh Gonzales.
and this is our presentation on the Ebola virus review and containment plan for the Nigeria outbreak.
Hello, guys. Today I'm going to be talking about the pathogenesis of Ebola virus. Uh, we're going to start off with the objective, talk about the brief history, transmission, the quick pathogenesis, and the symptoms. I hope you like it. Oh, my name is Cesar, by the way. All right, thank you. Let's get started. So Ebola was first encountered in Africa in 1976 in a country called the Republic of Congo. It was named after a river. So apparently, at that time, it got spread really bad because there were some nurses, there were nuns, and they didn't know any better, so they were reusing needles from infected patient. Uh, Basically using syringes over and over without sterilizing them, so they spread the disease even worse. So, quick history. Let's move on. Transmission. Ebola can be transmitted through bodily fluids. So when someone's infected and the fluid gets into another person's mucosal membrane, uh, that person gets infected. And then the studies have shown that uh, human originally got this virus through bats. Okay, the pathogenesis. So, the virus just gets through your body, through your mucosal membrane, your eye, your nose, you name it. So, after entering your body, the virus has this thing with your monocyte, macrophage, and dendritic cells. So, it loves those cells. So, what it does is it infects those cells and make them go crazy. So these cells starts to make cytokines and chemokines. They make so many of these things that it leads to thrombin generation. It leads to microvascular thrombosis, the dysregulation in the anticoagulant pathways, and then it destroys the fibrinolytic system. When this happens, the microvascular thrombosis causes a clot on the blood vessels, right? So when that happens, what happens next? There's no blood flow to the tissues, and what happens next? You get hypoxia, you got tissue death, skull necrosis. When this tissue dies, they release tissue factors, and these tissue factors, as you know, in coagulation, they even cause they worsen the progress of DIC. And of course, when this happens, you lose your platelets, the clotting factors. You're gonna lose so much of these things that you start to bleed, and you start bleeding all over the place. And when you bleed, when the patient bleeds so badly, they go into shock, drop in blood pressure, uh, hypotension, which is drop in blood pressure, and then ultimately multi-organ failure. Of course, when all this happens, it's just that's how patients that are affected with Ebola dies. Uh, Shock and DIC is what usually cause death in the patient. Uh, okay, let's move on. Some of the symptoms of Ebola: it has an incubation period that ranges from 2 to 21 days. Some of the early symptoms are fever, of course. Cytokines are released to the brain, so you get fever. You get tiredness. You get pains your muscle pains, and then this progresses to nausea, vomiting, diarrhea, coughing, and then of course it goes on to bleeding. Bleeding is the most significant part of the Ebola symptoms. You get the conjunctival hemorrhage, petechiae, vomiting blood, coughing blood, uh, your bloody diarrhea, and then of course it gets to the final stages, and which is shock, failure, and death. And that's it. Thank you.
Okay, so for the identification of Ebola, the most significant aspect towards diagnosis of the disease is going to be travel and patient history. So this may be seen later on one of your questions at the end of the presentation. One of the following conditions must be met in order for further laboratory testing to proceed. If, let's say, none of these are met, it is highly likely that the patient is experiencing another type of hemorrhagic fever, not due to Ebola virus. However, if one of the three of these three conditions are met, it might be likely that this person is has experienced exposure or is experiencing symptoms of Ebola virus, which then is confirmed via a screening test, which is a point of care test, and then confirmed with reverse transcriptase polymerase chain reaction, which is done in the laboratory. So common laboratory findings of Ebola virus disease is pancytopenia, increased aspartate aminotransferase and alanine aminotransferase concentrations, increased prothrombin time and partial thromboplastin time, which can then lead to disseminated intravascular coagulation, and then proteinuria, which can lead to acute kidney failure. So let's say that one of the following conditions earlier was met. We're going to go on to laboratory testing now. So the first one will be, this is the point of care test, the rapid antigen test, which is a chromogenic immunoassay done so by Corgenix. And then if, let's say that this is a positive result, then it will be pushed forward to the laboratory using reverse transcriptase polymerase chain reaction, in this case using Cepheid's Expert Ebola Assay Kit and Altana Diagnostics RealStar Filovirus Kit. So this is Corgenix's Rebov Antigen Rapid Test. And so what we can see here is that this is a rapid immunoassay that can actually take about 15 to 25 minutes, which is great for point of care testing. So let's say that you ask the questions and then you can do this on the spot in emergency situations. So Rebov antigen rapid test is detecting antibodies against the VP40 antigen. And so if you have a positive result, the test line as shown here will be present on the strip. So how this procedure is done is you take a sterile needle, prick your finger, and allow a blood drop to come out and be placed directly onto the strip. The strip is then placed into a test tube where the reaction takes place, and after a few minutes, detection of the control line and the test line indicates a positive result. So let's go ahead and take a closer look. So again, you place the blood sample right here on this end of the strip. The control line is necessary in order for this assay to be valid. If this is not here, this assay is not valid, and you will have to repeat the test. So this is indicating a positive result, and as you can see in strips 4, 3, 2, and even 1, that there is a test line present, which means that the patient currently has antibodies against the VP40 matrix protein. So again, just to refresh your memory, this is the envelope of the virion. The VP40 protein is embedded within the matrix. So antibodies against this protein right here on the surface of the virion is being detected and qualitatively represented as a line on the strip. So as you can see in strip 0, there is no presence of the test line, which means that this patient is currently not infected with Ebola virus in a detectable concentration. Okay, so let's take a closer look at what further laboratory testing looks like. So let's say after this Corgenix rapid antigen test did yield a positive result, we want to confirm that with a second, more sensitive and highly specific laboratory test. So the perfect one that is used and was recently used in the 2014 Ebola outbreak is reverse transcriptase PCR. So if you remember way back from molecular bio, PCR uses a DNA template instead of RNA. But as we know, Ebola is an RNA-based virus. So what we're going to be doing is we're going to use this RNA from the Ebola virus, and we are going to be adding dNTPS and buffers into the reaction mixture for transcription to occur. So dNTPS is short for deoxynucleoside triphosphates, which consist of 4 basic nucleotides, known as DATP, DCTP, DGTP, and DTTP. And these are all the 4 building blocks to create new DNA or RNA strands. So in this case, our goal is to create new cDNA. So the cDNA is going to be then used for our polymerase chain reaction to occur. So we'll be using these kind of laboratory-based nucleotides, really. You can think of them as nucleotides, and we will use them to bind as like primers and then bind to the RNA in order for transcription to occur. For transcription to occur, and then so what we want to do next is we want to be able to, we're going to heat this reaction and then allow for the cDNA to take place so that we'll prime it, replicate it, and then create DNA strands for PCR to take place, because PCR uses DNA in this case. This is a highly sensitive and highly specific assay, which yields more of the target RNA sequence, which is the Ebola RNA. So in this case, we used RealStar filovirus screen kit and the Expert Ebola assay, which the only reason why we're using 2 kits is because they target different regions of the Ebola virion. And all in all, this reverse transcriptase PCR assay has a greater representation of what we're putting into the instrument of the patient sample. So here's just an overview of what was just mentioned. So inputting of all the reagents into the test tube and allow for transcription, reverse transcription, and then PCR amplification to occur. And then what we have is this amplified cDNA. And again, here is a more simpler diagram for what was going on. So let me reiterate the RealStar and Expert Ebola assay. So what the Expert Ebola assay targets is going to be the nucleoprotein and the glycoprotein. So as we learned earlier, the glycoprotein is known for pathogenicity, and the RealStar will be targeting VP30 and VP35. And so these are important for the RD-RP complex, which is then very essential for the replication and transcription of the Ebola viral genome. So they're embedded in this complex, the RD-RP complex is the L protein. So that's actually what the RealStar will be targeting. So part of this is like the VP30, VP35, and the L protein. They all kind of work together, but what the RealStar PCR assay is actually detecting is the L protein within this whole complex. And so Expert's PCR kit detects nucleoprotein and glycoprotein. So RealStar assay takes about 2 to 5 hours to yield a result, 2 hours for a positive result, and 5 hours to confirm a negative. And for Experts, it takes about 90 minutes. And it's just based on the cost and the different types of various regions of the virion that we're detecting, and that's the only difference between the two, really. There are some limitations based on each assay, but as you can see, that the benefit is having the Expert is a little bit faster as compared to the real star, but the real star one is a lot more sensitive.
With all the information pertaining to genetics and mutation, it would be great to start with the intrinsic factors within humans that can affect how an Ebola virion can enter the human host. The only genetic abnormality that was able to be found was a defect in the NPC1 or HOPS, which involves the Niemann-Pick type C1 disease, in which the patients are therefore not susceptible to the virus. There was a study that was led by Dr. Pardis Sabeti at Harvard University and the Broad Institute. Samples were collected from the 78 individuals affected during the 2014 outbreak in Sierra Leone. 99 Ebola virus genomes were essentially sequenced, and as a result, 300 differences were found genetically between the strain as well as the strain from past outbreaks. It was known that there was a movement of the virus from Central Africa to West Africa over a span of 10 years. It was found that there were 50 mutations that came about during the spread of the outbreak. The study made it evident how important genomic surveillance is as a means to slow and track the virus evolution as the outbreak proceeds. Now let's get more specific. What specific mutations contribute to its increased pathogenicity? The article, Naturally Occurring Mutations in Ebola Virus Observable Impact Infectivity, sought out to essentially determine the specific mutations, or mutation in this case, that causes the virus to be more efficient in its infectivity. It was stated that there were many studies that narrowed the possible mutations to NP, GP, and I mutations, which all supported virulence. The result of the study was that it was found that the GP mutation was essentially what supported in vivo virulence, while the I mutation and the NP mutations actually decreased in vivo virulence. So let's dive deeper and give you an insight on the specific mutations in the Ebola virus glycoprotein sequence. In the article, Functional Mutations in Spike Glycoprotein of Zaire Ebola Virus Associated with an Increase in Infection Efficiency, the evolutionary mutations were studied, along with the relation to the viral infectivity. The analysis of the evolution of all Zaire Ebola virus glycoprotein sequences that was available, two codon sites were detected under the positive selection that was located near or within the critical region for the fusion of the host viral membrane. The specific regions that were detected were the alanine to valine and also the threonine to isoleucine mutations that were located at the position 82 or AA2V and 544 T544I. The variants of the Ebola virus that caused the 2014-2015 outbreak had mutations of AA2V that were fixed in the population, whereas the T544I mutations were not. To further add to this, it was previously observed that the T544I mutations had a much more significant increase in viral infectivity in comparison to the AA2V mutation. The study shows that there was a 4.3-fold increase in infectivity in strains that the mutation in the T544I from the original Makona strain, while the AA2V infectivity had only a 1.8-fold increase. Moving on to GP mutations and why it increases pathogenicity. Just to get the gist, glycoproteins interact with intercellular receptors after the event that it is processed by host proteases. Following this, the viral and endosomal membranes fuse with enhancement of the GP to complete the entry to the host cell. To get more into detail, surface glycoprotein is required in order to attach and fuse into the host viral membrane. GP has a structure that is described as trimeric with a perfusion conformation consisting of glycoprotein 1 and glycoprotein 2. They are bound to the neutralizing antibody. 3 viral attachment units then form a chalice that is cradled by GP2 fusion subunits. The glycocalyx surrounding the glycoprotein is likely what aids it in immune system evasion. This can likely be proved with the evidence that the survivors have such insignificant titers of the neutralizing antibody. Now moving on to the mutations that change the growth properties of the Ebola virus. Glycoprotein mutations have been acquired during the passage of the Ebola virus during tissue culture. This in turn changes the growth properties of the Ebola virus. 6 amino acid mutations were discovered to increase the growth of the virus in human cell lines. Mutations in these cell lines were found in GP2 fusion subunit, which increased the entry kinetics of the Ebola virus, as stated in the previous slides. It was also stated that the gain of entry has had two phenotypes, which was the heptide repeat 1, which decreased the cathepsin B activity required for a viral infection, and the other of which was a fusion loop mutation, which caused an increase in entry kinetics without the alteration in the dependence of cathepsin B. It was also stated that the fusion loop mutations that were present in the other Ebola virus glycoproteins demonstrated paths toward the evolution in order for functioning fusion loop maintenance under selection pressure that is optimal. With the mutations mentioned in the previous slide, one can produce inaccurate results during the process of therapeutic testing, as well as the distinguishing between the mutation in the tissue culture. Naturally occurring polymorphisms was very difficult in terms of the absence of the clinical glycoprotein sequences. Identification of these mutations, however, in the long run, will prepare researchers in the event that more mutations arise during the Ebola virus stock preparations. This in turn will increase the accuracy of the therapeutic testing. So in terms of another treatment possibility, tormephyrine is definitely one of them. As one now knows after all the previous slides, Ebola virus has a membrane envelope that is surrounded with trimers of glycoprotein that is essentially cleaved by an enzyme known as furin in order for the formation of GP1 and GP2, which are responsible for the attachment to the host cell, as well as endosomal entry and entry to the endosome, as well as membrane fusion. As a result of this, glycoprotein has naturally become a target for the development of antiviral drugs. Tormephine has been observed to display a capacity of binding between the attachment as well as the fusion of subunits GP1 and GP2 in the large tunnel entrance linking with the tunnels equivalent from the other monomers of the trimer that is located at the threefold axis. Tormephine binding causes the destabilization of the glycoprotein, triggering the premature release of GP2. As a whole, this action prevents the viral/endosomal fusion. The inhibitory mechanisms with this drug may essentially make a way for even more powerful and even more effective anti-Ebola virus drugs.
On October 14th, 2020, the US FDA approved Inmazeb as a treatment for the Zaire Ebola virus, which is manufactured by Regeneron Pharmaceuticals. It consists of a mixture of these three monoclonal antibodies, which I won't be pronouncing. They bind to the epitopes on the Zaire Ebola virus glycoprotein, blocking the attachment and entry of the virus into host cells. There are multiple vaccine candidates for the Ebola virus, but I will only be discussing the RVSV-ZBOV, aka Ervebo, which is the first FDA-approved vaccine on December 19, 2019. It was originally created by the Public Health Agency of Canada, but is now manufactured by Merck & Company Incorporated. It's a single-dose intramuscular injection on the deltoid muscle with a prophylactic intended use to protect against the Zaire strain of Ebola virus, and it should be used for those who are at least 18 years old. The vaccine consists of a vesicular stomatitis virus, VSV, which is an animal virus that can cause mild flu-like illness in humans. The VSV has been genetically engineered by replacing the VSV glycoprotein gene with the Ebola Zaire strain glycoprotein gene, which results in the production of Ebola glycoproteins on its surface, shown as the red circles. This is a replication-competent live vaccine, and it can provoke strong immune responses to the Ebola virus. However, it also has the potential to cause adverse events in humans, most likely those that are immunocompromised. There have been around 20 clinical trials assessing this vaccine in terms of safety and immunogenicity. The participants assessed in these trials have been mainly healthy adults. The dosages assessed were from 3 × 10 to the 3rd to 1 × 10 to the 8th plaque-forming units, with a preferred dosage of 2 × 10 to the 7th PFUs, as discussed in multiple trials. The reported systemic adverse events were mild to moderate and included headaches, fever, fatigue, muscle and joint pain, nausea, vesicular lesions, and arthritis. However, it's uncertain as to whether arthritis was caused by the vaccine or another confounding factor, as discussed in the Geneva Phase 1 trial, where arthritis was the first discovered. Possible vaccine-related serious adverse events reported include 1 case of fever and 2 allergic anaphylactic reactions. Vaccine efficacy. This is how well the vaccine works to prevent against developing the Ebola virus disease, and it's the percent reduction of disease in a vaccinated group. This ring vaccination strategy was assessed in the Ebola Sasufit Phase 3 trial in Guinea and Sierra Leone. And what this is an open-label, cluster randomized trial where clusters of people at high risk of infection were vaccinated. So first, the suspected cases of Ebola virus disease, EVD, were confirmed by lab tests. Then clusters of all contacts and contacts of contacts around that case of EVD are vaccinated, as shown in the picture. So 48 clusters were randomly assigned to receive immediate vaccination, and 42 clusters were randomly assigned to receive delayed vaccination after 21 days. The researchers and lab workers were not told the allocation to either immediate or delayed vaccination. However, since this is an open-label trial, both the researchers and participants know the treatment they're receiving, which is the vaccine. The results were that no cases of EVD developed in the immediate vaccination group, while 16 cases of EVD developed in the delayed vaccination group, giving a 100% vaccine efficacy for this trial. The World Health Organization reported prelim results of another ring vaccination strategy used during the recent Democratic Republic of Congo outbreak, with a total of 93,965 vaccinated individuals, giving a 97.5% vaccine efficacy. Immunogenicity. This is the ability to provoke an immune response, and it was assessed in these 2 trials, both of them being randomized, double-blind, and placebo-controlled. The results for the first trial gave a geometric mean titer, GMT, of IgG ELISA endpoint of 1624 and a seroconversion of 95.7% on day 28 of the preferred dose. These robust immunological responses sustained for 1 year. The second trial results showed the GMTs increased by 28 days post-vaccination of greater than 58-fold, which persisted through 24 months. Also, at 28 days, greater than 94% of vaccine recipients sero-responded, and 91% of these responses persisted for 2 years. Because the main participants in these trials have been healthy adults, more clinical trials are needed to assess the safety and effectiveness of the vaccine in these immunocompromised groups, including pregnant and lactating women, children less than 1 year of age, individuals with HIV, and geriatric patients. There have been many outbreaks, mainly throughout several African countries, since the first reported case of Ebola virus in 1976. The ways in which these countries dealt with previous Ebola outbreaks gave us insight as to what our containment plan should look like. I'll briefly discuss the largest Ebola outbreak to date, which was the West African epidemic in Guinea, Liberia, and Sierra Leone, with 28,610 cases, 11,308 deaths, and a case fatality of 39.5%. Compared to the other Ebola outbreaks, this case fatality was on the low end, as other outbreaks have had 60 to 100% case fatality rates. However, the amount of people infected in this outbreak was exceedingly more, and was also the most widespread. Containment of the outbreak was difficult because their overall public health infrastructure was weak, including their infectious disease surveillance systems. Strained lab testing capacity delayed the identification of infected patients, which delayed prompt isolation and treatment. Hospitals were filled beyond capacity and were not prepared for the influx of infected patients. Many healthcare workers became infected and some died due to poor infection control. And an initial lack of community education and engagement also contributed to the spread of the virus. In response, the CDC has contributed to the containment of the West African epidemic by deploying teams of specialists in many fields to the affected areas. They developed border and airport exit screening programs and improved surveillance. They established national emergency operations centers by using incident management systems, which helped strengthen communication amongst government leaders and partner organizations. They established and improved Ebola treatment units with better infection control practices and training of healthcare workers. And they established their own lab in Sierra Leone and developed faster diagnostic assays.
So now that we've discussed Ebola and the Ebola virus at length, we can discuss the formation of a containment plan for our hypothetical outbreak. The containment plan has three main phases, which include reactive measures, the treatment, and also constant interventions, and all three will funnel down into the ultimate containment of this outbreak. So here's some context over the outbreak that we're trying to contain. This outbreak takes place in the capital of Nigeria, Abuja. There are over 4,500 fatalities confirmed from Ebola virus disease over a 2-month period. So a little bit of context, this is almost half of the worst outbreak in Africa, which had about 11,000 deaths. So proportionally, we are dealing with a very large outbreak. And in turn, there is public panic. People are attempting to leave the country because of this outbreak, as well as Abuja is a high-risk area of transmission, meaning it has high population density in this city. So what do we do? Well, one of the first things to consider in mounting a response to such an outbreak is getting certain groups together in order to establish communication and cooperation between them. So groups like the NCDC, the Nigerian FMOH, the Federal Ministry of Health, as well as those directly involved in the treatment of Ebola patients, can meet with the CDC to discuss strategies and methods to contain the virus itself. And the CDC can provide them with additional trained individuals who are experts in disease control. Another important aspect of the government response is providing the public with transparent, scientifically backed information about the Ebola virus and the Ebola virus disease, how it's transmitted, and ensuring that people will follow the guidelines that they give on how to prevent the further spread of the disease itself. So once the government response has begun, the next step is assuming control of the affected area, which means setting up screening points and also setting up the contact tracing program. Screening points will help catch individuals who are symptomatic of Ebola virus disease, because the highest risk of transmission is through people who have symptoms of the Ebola virus disease. These individuals can then be placed in isolation where they can be tested, and if they test positive, they can be placed in the contact tracing program. This contact tracing program was effectively used in previous outbreaks. It's a relatively simple method of just monitoring individuals who have had the disease, as well as people who they have come into close contact with, effectively creating a chart of infected individuals across the country and following up with them on their treatment so that eventually the disease is stopped in its tracks. This is just a map of Nigeria, and I wanted to show you where Abuja was in Nigeria and the importance of the screening points and contact tracing program, because Abuja is right in the middle of Nigeria, and if people flee the city uncontrolled, they have the potential to spread it throughout Nigeria into other countries and also internationally, because Nigeria is capable of international travel from its airport as well as through seaports. The next step involves the treatment of those patients who have been placed in the contact tracing program and caught in the screening points. So the treatment of infectious disease outbreaks has been difficult for countries like Nigeria and other countries in West Africa, and the common theme is that there's never enough of the resources required to treat patients. While the CDC can help in this regard, providing resources such as hospital beds and volunteers and personnel, resources for laboratory testing, its most valuable asset is providing training of people already embedded in those hospitals and those field hospitals in infectious control practices as well as in personal protective equipment, which is the largest factor in keeping people safe in hospitals from being affected in hospitals and also keeping the health workers safe as well. So the last step of our containment plan is something called constant interventions, and what this involves is the continuous education of communities in high-risk areas of infectious diseases, educating them on hygienic practices, and also helping to develop infrastructure that supports a lifestyle that is hygienic as well. In a world where the Ebola virus vaccine is in the process of being improved or being developed, the most effective methods are keeping the public well informed on how diseases can spread to people and how it can spread from person to person, as well as ultimately preparing these communities and also the country in the case that another outbreak has the potential of happening. So, continuously working towards a well informed public, a better prepared healthcare system, and also the vaccine can help provide a environment where an outbreak can possibly never happen at all. So, the combination of government response and reactive measures, giving the public information about the disease, and also implementing screening and contact tracing programs, a well prepared healthcare system with trained individuals and resources to treat the patients, as well as constant interventions involving a well informed public, as well as the development of a vaccine for the disease, all lead to the eventual containment of this outbreak.
Q&A. Number 1. Bleeding is one of the significant symptoms encountered during an Ebola infection. This bleeding cascade is known as DIC, disseminated intravascular coagulation. Number 2. What is the most significant component in the identification of Ebola virus disease? A. Negative immunoassay test. B. Travel and patient history. C. Hemorrhagic fever. Or D. None of the above. The answer is B. Travel and patient history. Number 3. Out of the two codon mutations, T544I and A82V, which was found to display a larger increase in viral infectivity? The answer is T544I. Number 4. True or false? Vaccine immunogenicity is its ability to provoke an immune response in an individual. The answer is true. Number 5. Which action by the CDC is most valuable in providing aid to Nigeria? A. Giving monetary aid to hospitals. B. Providing training in PPE and standard precautions in hospitals. Or C. Mailing health information brochures. The answer is B. Providing training in PPE and standard precautions in hospitals.